I ended up on the floor on Father's Day. I didn't poop my pants, but it came real close. Attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse, and protectors of the developing brain. Welcome to the Cranial Doc Podcast, where we master the work that actually changes lives. Craniopathy, nervous system-based care, and the business systems that let you scale without selling your soul. I'm Dr. Anthony Pellegrino, pediatric chiropractor, certified craniopath, and proud automation geek. Let's dive in. All right, my friends, if you know me well, you know that I have a very dark sense of humor. And if you don't, then I am sorry in advance for what this episode is going to be, which is a funny story about what happened to me, with me, on Father's Day, and a little bit of how my brain works. So, and thank God it was Father's Day, right? So Father's Day morning, I had a little bit of an anatomy lesson, or a physiology lesson rather. I've recently just started working out pretty heavy again, and I never really did any bodybuilding type workouts or anything else like that. Kind of just been more functional movement, CrossFit based stuff, and I've been training jujitsu pretty hard, and I felt like I just lost too much weight, and I kind of wanted to get a little bit of strength back. So that is to say that I've been hitting deadlifts, which I've always done, but RDLs really hard. Romanian deadlifts, it just hit my hamstring, my posterior chain, just differently than it ever has before. Like, it's been really, really sore. That's important here. Just in a way that it has never been like that before. And Father's Day morning, I am getting ready to go work out or whatever. And my kids didn't finish the smoothie that my wife made them. So I stand back really quickly. I'm just going to go to the bathroom before I go to work out. So I go in there and I'm in a rush because I want to go and work out and get to my day and get this out of the way. And so I'm just pushing hard in the bathroom, right? And I give it one good last squeeze. All right? This is my humor. Sorry. And out pops the last nugget. And thus ensues the worst experience of my life. So the last little turd flies out, and my entire back and pelvic floor completely spasm all at the same time. I literally am pants on the ground, like on the floor, just in the fetal position, in 11 out of 10 pain. There's a pain going all the way back from the inside to my sacrum. My pelvic floor is overwhelmed. And I am just like cold sweat pouring out of me. Just completely lightheaded. I feel like I'm going to pass out. The room is spinning. And I am like violently dry heaving. So my wife walks in. Remember, she's had 3 natural births. Our second baby was 10 pounds, 0 ounces. And she could help me. Thank God it was Father's Day. Because she was like, this is your day. I'm going to not talk shit to you. But this is so dramatic. I'm on the floor for 5 minutes. It feels like 30. The only thing that stopped me from passing out was the feeling of somebody punching me in the colon from the inside. I'm in this pain, dry heaving, and also just laughing at the same time, trying to laugh in between the dry heaves, because I'm thinking about how all of these ridiculous symptoms, like I'm not dying, it's not a tumor, I am having a crazy vagus nerve response because my pelvic floor was overwhelmed. I drank something too cold too quickly, and then I took a poop. It was the push too hard. It was the perfect storm. So, we're going to go ahead and take this and learn from it together. And you'll be able to talk to people in your office better about of what the internet affectionately calls hot girl tummy troubles. All right. So I mentioned the RDLs because it wasn't to brag about my lifting or my lack of being able to do this. But what's important is that the posterior chain does not end at the glutes. There is a fascial continuity that runs straight into the pelvic floor. Romanian deadlifts and high heavy volume the day before meant that the tissue was already loaded and already sensitized and already reactive going into Father's Day. In fact, when you start working or referring or working with a pelvic floor physical therapist, before they ever get into the internal work that they're known for, most physical therapists will just get their patients working on things like hamstring function, addressing lower cross syndrome, and internal and external mobility of the hip, because that is all continuous with the pelvic floor to prep their body to be ready to be able to do that. So, on top of the strained pelvic floor, I had the cold bolus from the smoothie, and cold slows gastric motility, and it also activates the interoceptive lining in the gut wall, which starts reporting to them immediately. Because I was trying to rush through my morning poo, I had done a, maybe not maximum, but a good strong Valsalva as well, which spikes intrathoracic pressure and is a direct vagal stimulus. So I have all of this going on, this acute pain signal from the pelvic floor spasm, this sharp, loud, fast afferent input, and the nervous system on top of my post-exertion baseline from the day before, which was already covering, already sensitized, like all of those different things happening at the same time caused this massive vagus nerve response, which is related to the feeling, the interoception, the sweating, the lightheadedness, the spitting, all of it. And this is all important for us to be able to understand with our patients. So let's talk a little bit more about the vagus nerve. About 80% of the vagus nerve fibers are afferent. They're going up from the body to the brain, not from the brain to the body. Most people, especially in the holistic community that maybe don't understand afferentation, but they do understand the vagus nerve, think of it as a top-down nerve, like the brain is just sending calm signals to the body. But in fact, it is more about the parasympathetic. It's less about the parasympathetic output, the rest and digest, than it is the body feeding output up to the brain. The parasympathetic output is really only about 20% of what the vagus nerve does. 80% is on the way up. Your gut, your heart, your lung, your airway, everything is reporting that live picture of what's happening inside of you, interoception, to the brain. The vagus nerve is the primary driver of that. So when we understand that, when we put that in our disafferentation model of what we know about subluxation, how garbage in equals garbage out, that really changes everything that we know or what people speak about with dysfunction and places us even better for being able to help people with vagus nerve dysfunction, because it's not about what's going down, it's about the input and the sensitization that is going up. So let's just talk a little bit more about what the nerve actually touches. So we know the vagus nerve is the 10th cranial nerve. It exits the brainstem at the medulla. It exits through the jugular foramen, which for my cranial folks, is very important for us because of the occipitomastoid suture, which is where the occiput and the temporal bone come together, where the occiput should move into flexion extension and the temporal bone moves into external interrotation, and is a huge interface in cranial work for where we address dysfunction. Side note, I watched a dissection of the head and neck a couple weeks ago. There was literally changes in the shape of the jugular foramen, which is really interesting in a way that I never really thought of. Like, we know that, okay, it changes shape on flexion extension, but it's like, how much is that? And it's like, okay, maybe not in just the acute, but over the long term, the temporal bone can't externally rotate. That is going to, because of Wolff's law, actually change the size and shape of the foramen. And over time, it can lead to like more of a compressive type issue. Anywho, this nerve goes everywhere. It goes to the larynx, the pharynx, the heart, the lungs, the esophagus, the stomach, the small intestine, the large intestine, the liver, the bladder, the kidneys, the spleen. It's in your throat, it's in your chest, it's in your abdomen, it's in your pelvis. There is no other cranial nerve, no other nerve in the body that comes close to distribution. Vagus in Latin means wandering, you know that, and it earns that name. It creates the brain's picture of what is happening inside of the body, which comes largely from this nerve. Now, let's go through with that understanding and talk about exactly what happened to me. So all of that input that I just described, the cold bolus, the Valsalva, the pain, the loaded pelvic floor, all of that gets loaded up and hits a structure in the brainstem called the nucleus tractus solitarius, which we've spoken about a lot on this podcast. It's the primary processing hub for all of this visceral afferent information. It receives signals from the gut, from the heart, from the airway, from the brain pathways, and it integrates all of that and feeds that picture to the brain. When the nucleus tractus solitarius gets flooded, it activates a response. It activates the dorsal motor nucleus of the vagus nerve, which is cardioinhibitory output, which causes things like the heart rate to drop, the blood pressure to tank, and the nucleus ambiguus will contribute to bradycardia. There's peripheral vasodilation, which drops venous return and drops cerebral perfusion. Now, that is what happened when I ended up on the floor. I had the sweating, the diaphoresis, the nausea, the tunnel vision, the presyncope. It was a full vasovagal cascade, not a malfunction, but the nervous system doing what it was supposed to do because of this perfect storm of very, very, very loud input. Here's the part that I love, is it is the pain that saved me. Now, the acute pain signals triggered a competing sympathetic response. It's the reason that I didn't pass out. The body read that sharp pain as a threat and activated the sympathetic nervous system, which counteracted the vagal cascade and kept me from fully losing consciousness. So I want you to kind of think about this in terms of what's going on with your patients, right? The nervous system is absolutely wild. It's the pain, the pay attention inside now, that brings the attention to it, right? And is related to that sympathetic response. So let's just go ahead and take a minute and go a little deeper on polyvagal theory. Not crazy, just a little bit, okay? So we know Stephen Porges, we know polyvagal theory, and the basic argument here, basic, okay? If you're an expert in polyvagal therapy, don't at me. Let's just keep it simple. The vagus nerve is not one system, it is two, the ventral vagal complex. This is the newer myelinated branch that handles social engagement, calm, connection, eye contact, changes in the voice, the ability to be present with another, and when that branch is online, we feel very safe. The older unmyelinated branch is the dorsal vagal complex, which handles the shutdown, the freeze, the collapse, the dissociation. It's what happens when the nervous system decides that the threat is too big to fight or flee. It's a freeze and it goes here. And that's what happened to me on the floor with the dorsal vagal event. So acute, physiological, and triggered by like a storm of inputs, my nervous system decided this situation was overwhelming, so it basically pulled the emergency brake. Even though I wasn't in danger, the input said otherwise. So it responded to the signal that it was receiving. So this is what matters for people who are in your practice. When overloaded with these symbols, we talk a lot about this fight or flight response, right? And when we look at kids in the practice, we have to also look at the moments of not classical fight or flight, but shutdown, frozen, not being able to regulate, not being able to be reached. Their nervous system isn't broken. It's not that they need a diagnosis for this. It's that their nervous system has learned to cope, and shutting down is the safest response that is available. This is so common in individuals who have undergone physical, chemical, or emotional traumatic experiences and is the hallmark of dissociation. For anybody who's gone through any sort of trauma therapy or work with any patients trauma therapy, that dissociation is a very, very, very big part of it. Our job is not to force it out of that state. In fact, that would be counteractive, right? Because for many individuals who are maybe had a specific trauma or specific loaded stimuli that put them in this state, if their body's created safety by going to this overloaded state, and that's how they feel safe, they might not be out of that storm, right? If the bad input has caused the nervous system to intentionally make a shift to safety, right? And we just start to try to get them out of that, and their nervous system is still overwhelmed and overloaded, we've now hardened that, right? We've told the brain, you need to shut down even more. So our job, and this is very important, not to get down the rabbit hole of your patients with anxiety, depression, trauma, that's a large part of my practice. It's something that I have a lot of personal experience with, and so I just know how to work with individuals with this, right? And so there comes a point and I kind of like to, when I speak with somebody who maybe is healing with something where they had a big traumatic event and they maybe have this fight or flight response or freeze response that's helped them. One of the things that's really important, and they should be talking to a therapist about this, of course, is recognizing, okay, and this is just a big part of healing, that response, that thing, that personality change, that thing that they had for a reason. And it served them for a while, right? There's a reason that they did that. But if that stimulus is no longer there, and this is a big thing with somebody who's undergone like a one-time massive trauma, right? Whatever it is, whether it was abuse or maybe not one time, but like a period of life of trauma, maybe abuse, maybe, survivors of 9/11, stuff like that, right? Or survivors of school shooting, that stimulus is no longer there, right? But that ingrained fight, flight, freeze response was so large that it protected them in that moment. But that stimulus is no longer there. So they want to work to the place where they can thank that activity, thank that response, thank that personality type, thank whatever it is for how it served them, how this served me in the past, but I no longer need this. So thank you for your service. I no longer need to feel this way. I no longer need this shutdown. I know that was kind of long-winded. I didn't plan to go down that rabbit hole, but hey, that's Listen Talk to Me. Okay, that's how I think. So essentially, we want this person through therapy or whatever, wants to get to the place where they can thank their nervous system, saying, hey, thank you for protecting me. I no longer need this protection. This was great. It served me for a period of time, but like you are released and you've done your service. You no longer need to do your job. Well, we have to recognize that for the individuals who have this traumatic response from physical, chemical, emotional stressors, from improper afferent input to the brain, they might not be out of that storm. And we don't want to force them to change that. Our job is to change the structural input, right? I didn't mean to go down that, but I just want to sit with that for a second. We don't necessarily need to change the symptom. We don't need to snap them out of fight or flight. We need to change the input going up to their brain so that their nervous system can now be in a safe space. So because it's in a safe space, it no longer needs that fight, flight, or freeze response. So let's kind of recap what this looks like in practice, right? The vagus nerve is not an abstract concept. It's sitting in front of you every single day. It's influenced by the upper cervical spine, especially the occipitoatlanto, and especially the jugular foramen, occipitomastoid, occipitotemporal. Like, it is influenced by everything that we do on a structural basis, on a physical basis, by helping people feel safe in their body and their nervous system. 80% of it is afferent input that is going up to the brain and is regulating the state of our patients that come in. A improperly functioning vagus nerve can lead to dysregulation, hypervigilance, shutdown, chronic sympathetic lock, and inability to settle, all of it, right? It's not that these are personality traits. Again, these are ways that the nervous system learned to deal with this and cope with this aberrant input. They are interoceptive states that are being reported upward through the vagus and being interpreted by the brain as either threat or safety. So who is this impacting? The colicky baby who can't settle, whose gut is constantly in distress and is living in a constant afferent barrage that is firing upward through the vagus. The kid with chronic ear and sinus issues. The vagal branches innervate the larynx and pharynx, and the eustachian tube is involved. The whole posterior cranial base. They are not separate problems. They're expressions of the same structural and neurological environment. The dysregulated toddler, the terrible twos, the three-nager, sensory overwhelm as part of an interoceptive flood. Too much input, too fast. The nucleus tractus solitarius gets overloaded. The vagal complex overloads. We have meltdown, shutdown, or both. Elevating to the teen who's completely shut down. Again, dorsal vagal freeze. No one can reach them. They're not choosing this. Sometimes, the cases that we're talking about, they're in a physiological state that their nervous system has learned is the safest place to be because of the afferent input that it has been receiving. The adult with those random unexplained symptoms that's been chasing doctor to doctor to doctor. The GI issues that affectionately the internet calls hot girl tummy troubles. The heart rate variability problems. The fatigue that does not resolve with rest. The vagus nerve is a thread running through all of it. It is not our goal to diagnose vagal dysfunction. We are not treating any of these conditions. What we are doing is identifying a structural contributor to the dysfunction, to the environment the nervous system is operating in, and correcting the subluxation pattern that is driving it. That is our lane. It is important. It is overlooked. It is the thing that only we can do. And for many of these families, it is the missing link to their healing. So, to recap, the vagus nerve exits the skull through the jugular foramen. It's a channel that's formed by two bones, the occiput and the temporal. This is where we put our hands when we're doing cranial work. If you don't know what you're doing with the occipitomastoid suture, right now, go to thecranialdoc.com/training and sign up for the upcoming Foundations of Cranial Adjusting course. You need to be there. You need to learn this. The future of your practice and the future of our profession depends on us mastering this thing that is right in front of us. You should be working with that junction every single day with every single patient. That is our territory. That is where we are the best. We want to not just check the temporal bone, but we also have to check the occipitocondyle, occipitoatlanto. So even if you're not doing cranial work, and if you're only looking at C1, C2 and you stop, you gotta look at how the occiput and the cranium itself articulates with the spine. That occiput is a massively important joint that I think is overlooked because we put all of our focus on C1 and C2. Again, we're not claiming to fix the vagus nerve. We're identifying a structural pattern that changes the environment that the nerve exits through. It changes the afferent input that is going up through it. So, the baby who settles after we address this, we expect to see things like their gut symptoms improve, the teen who finally starts to open up after consistent cranial work. Those outcomes are not magic. They are just mechanically coherent when we understand what the jugular foramen and the cranium holds and what we are actually doing. So, too long. Didn't read. I ended up on the floor on Father's Day. I didn't poop my pants, but it came real close. There were 4 inputs that hit the vagus nerve at once, and it did exactly what it was designed to do. My nervous system wasn't broken. There's nothing wrong with me. I don't have a tumor. My body was responding appropriately to the signal that it received. All of your patients are their own version on the floor. Sometimes literally, right? Sometimes neurologically, sometimes acutely, more often chronically. They've been there so long that that's just what they think is normal. We do our work on the spine. We balance the input going up. We do our work at the posterior and the entirety of the cranial base. This is how we help get up. That is why this nerve matters. That is why this work matters. Thecranialdoc.com/training. Sign up for the upcoming Foundations of Cranial Adjusting course. Let me know if you can't find a date that works for you. And let me help you implement this work at the highest level. Not just because it will make your practice and life better, which it will, but because it will help you get the best outcomes for your patients doing neurologically based chiropractic care. Thank you for listening to another episode of the Cranial Doc podcast. I hope you got a ton of value out of today's episode. And if you did, it would mean the world to me if you jumped over to iTunes or your favorite podcast player of choice and subscribed, rated, reviewed, and shared this episode with a friend that you know could benefit. We have a ton of this information and more in our free email series at thecranialdoc.com. So go ahead and jump on there, subscribe, and get me raw, unfiltered in your inbox every week, changing your practice. Can't wait to see you for the next episode.